I just want to say that it's one of the biggest privileges we can have as physicians to be able to talk to patients, because we usually talk to each other in 3- and 4-syllable words. So it's really nice to talk to the people that we give the care to, and because we know how much you guys appreciate hearing it directly from us. So thanks everybody for being here and for inviting me. So I'm going to talk about the surgical management of small bowel and pancreatic neuroendocrine tumors. These are the most common tumors that we as surgical oncologists will take care of. And this slide basically shows that the incidence of these tumors have increased remarkably over the last 4 decades. As Dr. Hafdonerson mentioned, they started out about 2 cases per million in 1973. Now PNETs are about 8 cases per million, and SBNETs are 12 cases per million. So they're becoming more and more common, and whether this is due to earlier diagnosis by CT scans, whether there's something in the environment, we really don't know. So let's start by talking about SBNETs. These are the most common GI site of neuroendocrine tumors. The incidence is 12 per million, and about 50% of them are multicentric. And what that means is that if you are looking at the small intestine, there's going to be more than one tumor. It might not just be one. Most of these are well differentiated, as Thor mentioned. That means slow growing or not having a lot of cell division. But even though they may be slow growing, they often present late. And what we mean by that is many of the patients that I see have metastases to the liver at the time of diagnosis. This is a typical patient that I might see in the office who has a SBNET. He might have had 5 or 10 years of diarrhea, some crampy abdominal pain, some flushing, especially after having a glass of wine. And on a CT scan, we can see this mass in the right lower quadrant. And again, when you look at a picture of a CT scan, just imagine the legs are coming towards you and the head is on the other side, and we're taking a cross section. So the arrow designates this thickening of where the small intestine meets the large intestine. Immediately next to that, we see some flecks of calcium in some lymph nodes that are just adjacent to it. And then if we look at a lower cut of the CT scan, we see thickening of this loop of intestine down in the pelvis, signifying chronic obstruction. When we make the diagnosis of a small bowel neuroendocrine tumor, we'll often suggest that they have surgery. And the extent of that surgery and how big the incision is really depends on the extent of disease. If there's a lot of liver disease and we're going to do liver debulking, we're going to make a large incision. If we're just going to take out the tumor, we can do it through a relatively small incision, usually in the midline as shown in this picture. Most important thing is when you get into the abdomen is to what we call run the small bowel. And what that means is to palpate or feel between your fingers the entire length of the small bowel. This is usually about 500 centimeters or 15 feet. And again, the reason this is so important is that over half the people have more than one tumor. So if you do a case, say, laparoscopically, where you're using metal graspers to feel the intestine, you're often going to miss smaller lesions. This just shows what the small intestine looks like. In my hands are what look like normal small bowel. And then below it, you can see this very thickened, chronically obstructed small bowel here. And these silk threads designate areas of multiple small bowel carcinoids, but really the big one in this particular patient is shown here, where you see this white tumor that is obstructing or blocking the bowel. That's why this bowel is very thickened, and the food that the person eats is having great difficulty getting through this spot. And so chronically this is getting enlarged and this is decompressed beyond it. This is what a bowel obstruction looks like. This is just a recent study where we looked at all our patients that had small intestinal tumors, and we tried to show where they were in the small intestine. And if the small intestine is 500 centimeters long, we only found one that was in the first 100 centimeters, and 78% were in the last 100 centimeters. So these tend to cluster at the very end of the small intestine, but they can really be anywhere along it. And like I mentioned, many of our patients had more than one tumor. And so this shows all the patients that had more than one tumor, the length of where their tumors were distributed, and the number of tumors. And you can see that one of these people had 129, or this guy right here. So again, this is the importance of feeling the entire small intestine to find these lesions. This just shows a tumor down here, and what happens is the tumors drain along lymph nodes. the small intestine is suspended on something called the mesentery. The mesentery brings in the blood vessels, as you can see here, and along those blood vessels are the lymph nodes that drain from that area, and that's usually the first site of metastasis to these lymph nodes, and then it goes from here up to the liver. And the strategy surgically would be to remove this primary tumor and the involved lymph nodes here by taking a wedge of the mesentery with a section of the bowel. Now I talked about laparoscopic. We've really moved in surgery to doing things through smaller and smaller incisions, but sometimes that's not always in the best interest if you're going to miss lesions. This just shows a patient that we operated on for carcinoid syndrome, and we took out the primary tumor through a very small incision, and you can see in this person there are 8 separate primaries designated by these threads. There's an enlarged lymph node. It's probably hard for you guys to see, but we could do this through a pretty small incision. This shows us joining the bowel together with a stapler. So after we resect it, we bring it together, we staple it back together again, and then this individual's incision wasn't really very large at all. Now again, most of my incisions are much larger because I'm doing liver debulking, and Dr. Keutgen is going to talk about that in a second. But you can do it through a pretty small incision, and when people do it laparoscopically, they use an incision like this anyway to hook up the bowel together. So the important thing is if somebody's going to explore you laparoscopically, that they feel the entire small intestine through that small incision, which you can do. Now some people have more advanced cases, and this just shows somebody with enlarged lymph nodes around the superior mesenteric vein and artery. That's the vein that brings all the blood flow from the intestine to the liver, and the artery that brings it down to the small intestine. And this is a crescent of lymph nodes that's completely surrounding those vessels. And those are really important vessels, and sometimes these lymph nodes can be like cement, and this is a very difficult situation, and sometimes it's not possible to remove all of those lymph nodes. Another situation that Dr. Keutgen is going to talk about is patients with liver metastasis. And here we see a liver metastasis in a patient with a small bowel neuroendocrine tumor and a couple more. And so we often are going to need to deal with that at the same time. Now, how do patients do with PNETs and SBNETs? This is a series that we looked at from several years ago. And basically in the blue you see the survival curve of patients that have SBNETs here, and in the red is the PNETs. Now of the patients that we took care of here, 81% of the SBNET patients had liver metastases and 38% of the PNETs had liver metastases. If we look at how long they lived, the 5-year survival of each of those groups was about 79%. And this is from the age of diagnosis. In other studies, this is age of surgery. In a lot of studies, they look at age of diagnosis, which can add 5 or 10 years onto that. And at 10 years, the survival is about 57 versus 53%. And again, there are differences between these patients in terms of liver metastases, but this just gives you a general idea in a surgical series of patients, what the average lifespan might be. So the benefits of taking out a primary small bowel neuroendocrine tumor, there are many, and this includes patients who have advanced disease to the liver even. It can prevent future metastases to the liver. It can prevent obstruction. So you saw that case, that person has a bowel obstruction, they're going to have a problem, not going to be able to eat after a while. It prevents bleeding. Not everybody has bleeding with these tumors, but if you do, this can be very helpful. Sometimes the tumor will grow through the wall of the intestine and spit off small cells that will implant in the abdominal cavity. Those are called peritoneal metastases, and that can cause a lot of problems down the road. It may reduce hormone levels, but there's some evidence in retrospective studies that it actually improves survival to take out the primary tumor, even in the presence of liver metastasis. This is controversial to some of our medical colleagues, but there's pretty good evidence that this may be the case. We also recommend that if you're going to have an operation for a small bowel tumor, that you have your gallbladder removed. The reason for that is when you're on somatostatin analogs, you're going to eventually develop gallstones. Not everybody's going to develop problems where they're going to have their gallbladder out, but if somebody's in the abdomen doing another operation, it makes sense to take out the gallbladder. Also, for patients who get hepatic embolization for liver metastases, sometimes it can knock off the artery to the gallbladder and cause that to necrose. So just if somebody's in there already, it's not a bad idea to take out the gallbladder. Now let's just talk briefly about pancreas tumors. This just is a picture of a pancreas tumor here on the left, and on the right is where it comes from, a normal islet cell. And in the pancreas, about 5% of cells make hormones like insulin. The other 95% make pancreatic enzymes. But it's these cells, the islet cells, that turn into these tumors. And these tumors, if they don't make a hormone, they're called nonfunctional. If they make a hormone, we call them functional, and they cause a variety of different syndromes, as Dr. Halfdonerson mentioned. Insulinomas make insulin, and people get low blood sugars. Gastrinomas make gastrin, which causes high gastric acid output, which causes duodenal and small bowel ulcers and problems from that. VIPoma, glucagonoma, and somatostatinomas all cause diarrhea and other symptoms. And then another tumor marker is called pancreatic polypeptide that doesn't really cause symptoms, and they're considered non-functional. Now, when do you take out a pancreatic primary tumor? Well, if it's making a hormone and that hormone is causing a problem like low blood sugar, it really should come out. If it's not making a hormone, or if it's making pancreatic polypeptide, then it's not as important. But if that tumor is over 2 centimeters in size, there's a good chance that it's going to start spreading to lymph nodes in the liver, and that could limit the patient's lifespan. So those should come out. If it's less than 1 centimeter, a lot of those tumors may stay that size for a long time, and they don't necessarily need to come out because the risk of spreading to the liver or to lymph nodes may be low. Again, if it's not making a hormone and it's small, and it's incidentally picked up on a CT scan for kidney stones, it can be watched, but it has to be watched to make sure it's not growing. In tumors that are 1 to 2 centimeters in size, there's a little more controversy about whether they should come out, and we don't really have time to go over all the arguments there, but that's kind of more of a gray zone. If it's a high-grade tumor, if it's isolated, there's a role for resection. But if there are extensive liver metastases and it's high-grade, then often the patients will have problems from their disease that are better treated with chemotherapy than surgery. And finally, if patients have a familial syndrome like multiple endocrine neoplasia type 1 or von Hippel-Lindau syndrome, if the tumor is over 2 centimeters, that may also be an indication for its removal. Now, there are a lot of different operations you can do. If the tumor is small, you can do something called an enucleation, and that's basically shelling the tumor out. So this shows the tumor here, and this shows after it's removed where you just come around the edge of the tumor. And this is pretty good for benign tumors or insulinomas, and some other tumors are amenable to that, but not all are. Now, when you look at this picture, also take note of the fact that the pancreas has this certain shape and that it's intimately associated with the duodenum, and behind it run the superior mesenteric vein, which takes all the blood from the small intestine up to the liver, and the superior mesenteric artery, which brings all the blood flow into the intestine. So the spleen is out here, and the splenic vessels travel through the back of the pancreas or along the edge of it, and that makes some of the operations require removing the spleen, for example, such as in this case where a patient has a tumor in the tail of the pancreas, and you can see this bulky lobulated mass here. In that person, we would do a distal pancreatectomy. And what we do there is we divide the pancreas over those blood vessels I mentioned and take that tumor out with the spleen in the body of the pancreas, and then oversew the head of the pancreas. This is what a specimen looks like. There's the tumor. There's a 1 centimeter margin of normal tissue. Now, if the tumor's in the pancreatic head, such as this person's here, and this is an enlarged lymph node, and actually this patient has a tumor thrombus moving up the vein into the liver, then this is a little more complicated. Then the patient needs an operation that's a little bit larger called a Whipple procedure. And this just shows that operation. And here is the head of the pancreas with the tumor. We've divided the tumor over that vein. We have to remove the entire duodenum. We have to divide the stomach. You have to divide the bile duct. And then when this comes out, there's a pancreatic duct that needs to be hooked up to the intestine, as well as the bile duct up here in the stomach. And so it's a little more involved, and you need to reconstruct a patient like this. Pancreatic operations generally have a little higher risk than, say, the small bowel operations we talked about earlier, and there are more potential for complications. There is a role for laparoscopic removal, which is pretty good for small lesions in the tail of the pancreas. You can also enucleate with a laparoscope, and it's very well suited for this distal pancreatectomy. And this just shows mobilizing using graspers the pancreas up off the splenic vein and artery. You would divide the pancreas here with a stapler and then take out the tail of the pancreas with or without the spleen. So smaller tumors in the tail can be treated this way, but large tumors require an extensive nodal dissection and may have liver metastases that need to be dealt with as well.
As we talked a little bit before, it's important to know first of all, is the disease localized or has it spread, right? So if you're diagnosed with a neuroendocrine tumor and it's localized, you want to make sure you go see your surgeon, preferably Jim or me. I'm just kidding. And we'll resect it, and then we'll watch you. But if it has metastasized, and the most common site is the liver, and I'll talk to you about that in a few slides, then the question becomes, what do we do? Do we take the primary tumor out, as Jim said, even though we may or may not be able to resect the liver metastases? And then if you have liver metastases, is there heavy tumor burden, light tumor burden? How do we define this? These are all things that we are actually currently still doing research on, but there's many options, as you could see here, in patients that actually have liver metastases on how we can treat them. Surgery is one option, but there's obviously liver-directed therapy with IR, and Riyad is going to talk to us about that after this talk, and then sandostatin, lanreotide, everolimus, and PRT, etc. So it's very important, in my opinion, to look at the liver. Why? Because classic cancers, this is from Rod Palmier's study, usually have a larger primary tumor and then a smaller amount of lymph node metastases or distant metastases. So we're talking, for example, about colon cancer is a classic example. Small bowel neuroendocrine tumors or pancreatic neuroendocrine tumors, it's a little different. Often we see very small primaries, especially for small bowel, but a really significant amount of lymph node metastases and even a higher burden of distant metastases. And sometimes it's even small for us to actually find it's hard for us to find the primary tumor, especially if it's in the small bowel. But as Jim said, when we do the operation, we run the small bowel appropriately, we can actually find it in a majority of cases. So the number one cause of a decreased lifespan in neuroendocrine tumor patients are liver metastases that become so overwhelming that the patient gets into liver failure. So the liver is really an important prognostic marker next to the grade of the tumor. So treatment options of patients that have liver metastases are, as we heard before, systemic therapies, but also liver-directed therapies. And in those we have surgical resection and debulking, as well as liver-directed therapy. Y90 is one example. And then very rarely liver transplant. I'm not going to talk about that today because we don't have enough time, but it's very rarely used, but it can be used in very selective cases. So the limitation of systemic therapies for liver metastases, so everolimus, octreotide, etc., is that there's really very limited studies that show us specifically what these therapies do with liver metastases. So if you look at sandostatin or lanreotide, we know from if you dissect out the study that came out a few years ago, that really they become a lot less effective once you have a higher burden of liver tumor. We have no data whatsoever from everolimus on how good this works really for liver metastases. And then even PRT, we have very limited data, or actually no data, but there hopefully is some data that's going to come out soon to try to understand, is there a certain size of liver lesions that PRT work better on or less well? Does the tumor burden matter? So we're trying to still understand this, and so far we don't have a lot of good answers. So why do we do surgery for liver metastases? Well, we know that surgery is the only potential cure, although we have to be very careful, and I always counsel my patients that even though we can resect sometimes all the liver metastases, there's still a high chance that they will come back over time. There seem to be some survival advantages of those patients that undergo surgery versus no surgery. As Jim mentioned before, the medical oncologists and the surgeons are debating about this because of the study designs. And the surgical debulking concept, which Jim has actually written a lot about, really came out a longer time ago, where we thought to debulk, so resect these liver lesions, mainly because patients had hormonal symptoms and we didn't really have any good drugs, such as octreotide. And we noticed that if you take more than 90% out, these patients seem to live longer, even though you leave some of the tumor behind. And now that's been lowered, that threshold, to 70%. And that's important because this is one of the few tumors that actually debulking can be used in. So we don't always have to take all the tumor out. And then the famous objective response rate is what we say is, when we give a patient a treatment, what is the chance that the tumor will actually start shrinking or disappearing? Well, most medical therapies have really a lower threshold, and even PRT is probably in the 20 to 30% range. With surgery, we can obviously do better, because if we can cut 70% of the lesions out, then that's helpful, we think, at least in some cases. But there are sometimes problems that we need to know about in surgery, although I have to say the complications have much decreased with liver surgery over the last decade, because there's newer techniques that we use, and I'll show you that in a second. So when do we operate on the liver? Well, we operate on the liver when we think we can take all the tumor out in the liver, or if we can achieve at least 70% cyto reduction, so reduction of the tumor volume. We don't operate in patients that have grade 3 neuroendocrine tumors, or very rarely. So mostly that's reserved for grade 1 or grade 2. We want to make sure the patient is an acceptable risk to go through surgery. Obviously, we don't want to harm the patient long term by recommending surgery. So we have to make sure that you'll be able to get through surgery. And then when the liver function is still normal and no other liver-directed therapies have been used. Now, Riat is somewhere here in the room, and he's probably going to argue with me about this. And we can sometimes operate on patients when they have had Y90 or like other liver-directed treatments, but we don't necessarily always like to do that. So how do we plan liver surgery? Very briefly, we do a CT, triple phase IV contrast. I'm a big fan of MRI with EOVIST. Everybody that has ever seen me in my office knows that I will recommend that, because I think it's and there's actually studies to support this, the best modality to actually look for liver tumors, because there's a lot of things we can see on the MRI that even on a good CT you may not be able to see. Sometimes we use gallium dotatate, and more importantly, we really use ultrasound during the operation to help us guide where these tumors are. So that's the liver here. And not to go into too many details, but essentially there's an inflow in the liver and an outflow in the liver. So the blood goes in and the blood flows out, right? So we have newer things right now that we can. How do I play a video? That's a big question. Can somebody play it for me? So we have. Do I press in the middle? Yeah, thing in the middle, point it toward. Oh, there we go. So we have newer therapies, actually. Newer preoperative things where we can use MRI or CT to actually help us define where the tumor is. That's 3D reconstruction. Particularly helpful because, as you know, all these big vessels that you see on the left side, we want to try to preserve the inflow and the outflow of the liver in most cases. And so it's important for us to understand what the relationship is to those in a three-dimensional way. So we occasionally will use that. That's another way to look at this. This was the classic way on the left side, where you have many lesions that are in yellow here, and we would classically take out a big chunk. But nowadays, with this 3D reconstruction and with newer techniques, we can actually really try to make that a lot smaller, so resect less liver volume. And I think that's really important. This is what we do. We try to carve these lesions out as much as we can. And those that we can't carve out, we try to ablate them, so we burn them. And I'll show you an example in a second. That can be done both laparoscopic or open, although when we have multiple liver lesions and we have to carve out 10, 20, 30 lesions, laparoscopic is not really an option anymore. But we can do it with keyhole surgery if it's a few lesions. Now, this is an example, for example, of a patient that came to us. This is an MRI with EOVIS. Everything that's red are liver tumors here that you could see, many of them. Some of them localized pretty centrally. And so a lot of surgeons would say, well, you probably have to remove the entire right side of the liver. Again, for neuroendocrine tumors, we really try not to do that. And I'll tell you in a few minutes why. And so we opted to do what's called a parenchymal-sparing approach. So we went deep into the liver. We carved them out. Some of the lesions we burned down, and we took part of the vein here and part of the artery and vein over here. And we were able, this is just an example on how we work, not to be too graphic here, but basically what this shows is that we have this little device here that's called the CUSA. It helps us aspirate a lot of the liver cells. The tumor is this round ball here, and essentially we have very little blood loss. By aspirating the liver cells, all that's left are the bile ducts and the blood vessels, and so we can just take a clip when we see a bile duct or a blood vessel, clip it like we do here, and then we basically divide that structure, and we have very few bile leaks and very little blood loss by doing this. So this is a newer technique that has emerged probably over the last, I would say, 10 years or so. And so this is this concept of parenchymal-sparing resection. We try to leave as much as the liver there because we can really just carve these lesions out without very little blood loss, as you can see here. So this is, hopefully it'll work. No, I don't know. Yeah, so this is an example of a liver that we had debulked. So we resected all these lesions here. We carved all these things out. And the nice thing with neuroendocrine tumors is they are often very they have often a very strong capsule. So you can really just carve them out. And you can see all these holes here in the liver, but the entire organ stays intact. So we keep the inflow, we keep the outflow, very important because it helps us also to be able to reoperate in some of these patients. This is a newer technique to ablate these tumors, really nice. You could stick a catheter under ultrasound guidance in the operating room straight into the tumor, gives you exactly in a three-dimensional plane where you are, make sure you're in the middle of the tumor, you ablate it really well, and then you have this nice little circle that will tell you exactly what you're burning, because you don't want to burn too much healthy liver tissue. Again, you want to just take that out where the tumor is. This is just an example of one of these tumors that we resect. So why parenchymal-sparing surgery? That's the last thing. There's just a little series out of MD Anderson. This came out for actually colorectal liver metastasis, not neuroendocrine tumor metastasis. But they compared all the colorectal liver lesions or patients with liver lesions over time. And essentially what they did is, if I get to the next slide here, maybe not. No, there we go. That they compared cutting out a little bit versus an entire lobe, which is the usual way to do this, which was a much bigger operation. And they actually found out that there's a big difference, not in terms of patients having the tumor come back, but in terms of survival. And one of the reasons, and again, this is colorectal, one of the reasons why they thought that this was the case is because they could, by preserving inflow and outflow of the liver, they would be able to reoperate on these patients later on. So if we operate one time on you and we have taken some of the tumor out, it doesn't mean we can't reoperate on you. And using these newer techniques, it allows us to reoperate on you later on. So I think there are really exciting times ahead in the neuroendocrine tumor world. I think that with liver-directed therapies, including IR, including surgery, including these neurosurgical methods that Jim and I do, with systemic therapies such as PRT and newer things that are coming out, I really see this as a combination. I don't think that surgery is the cure for all, especially if your tumor has spread to the liver. But I do think that if you're a good surgical candidate, it can definitely achieve a lot and give you a lot of life years to live, especially if you combine it with systemic therapies. Now, all the brains in the room just have to figure out what are we going to use first and how are we going to combine it. But we'll get there, we promise. All right, thank you very much.